running pretty much on time. I have obviously a presentation that's way too long, so I'm going to race through some of this stuff. You will have the presentations available to you at the end of the whole course, and I'll be around. You can always ask me questions if you have to. I prefer you didn't. Anyway, so as far as dissections, is there there's nothing to look at up here? Oh, over here. Okay. No, I got a different pointer here, yeah. So if you look at just the definitions of acute dissection, and I'm probably going to challenge some of these along the talk, but if you know kind of standard what it is defined as, acute is defined as somebody that has a dissection within 14 days of symptom onset, and then chronic beyond that. And that was really based on old data way back from the 50s, and really was based on autopsy reports. For a complicated dissection, we're going to talk about this several times throughout the talk. Essentially, end organ ischemia or malperfusion, as you know, refractory hypertension, rupture or impending rupture, and then uncontrolled pain. And then, of course, there's the uncomplicated dissections. So we go with really two main classifications. The more simple is Stanford. Type A is anything involving the ascending, and type B is anything involving the descending. And DeBakey kind of classifies it a little bit further into 1 and 2, which involves the ascending, and then 3A and B, the B being the more extensive of those two. As far as demographics, 80 to 90% of patients are 60 years or above and have arterial hypertension. Acute dissections involve the ascending in patients who are generally a little bit younger. Arch vessel occlusion, about 5 to 10% of those with type A dissections. If you look at patients who have dissections overall, if they're going to have ischemia of a leg, it's generally the left leg. And so that's where you should be following. Interestingly enough, a lot of times you may have a stronger pulse in that left side, although that's where they're complaining of symptoms. Of course, they may have become anuric or have decrease in their urine output. And then hemodynamic state, of course, they can have sudden death, and this would be a free rupture of their false lumen. They can have acute aortic insufficiency and cardiac tamponade, all things you should be looking for. As far as type A dissections, of course, you know that they are emergencies, and we consider about 1% mortality rate per hour. Operative repair still has a pretty high mortality rate, and that's about 30%. Generally, you want to do the least possible, and so most of the time that's just an ascending replacement. Sometimes you'll have to suspend the valve. Of course, you'll know going in whether that valve is incompetent. Generally your anesthesiologist will be doing a TEE for you. The complications are significant: stroke, bleeding, death, multi-system organ failure, and MI. Seems like with all these talks, we're really trying to encourage you to go into vascular. Unfortunately, you've already committed yourself. Symptoms and signs, the most common are sudden severe back and chest pain. Generally, most patients will describe it between their shoulder blades. That's about 90% or greater. Pain into the abdomen, so that could actually be misleading. You may think it's something else, and that is related to the aortic tear or mesenteric ischemia. Hypertension, of course, is 70% or greater in distal dissections, and less than 50% proximal. You may also see syncope in 15 to 20% of patients. If you go through some of the diagnostics, of course, you can do a chest x-ray. You can see widening of the mediastinum, as you see in that picture, but that's not obviously your mainstay in how you're going to diagnose these. Contrast CT is probably the most common, and then echo or TEE, particularly for type A dissections. And then if you were going to look at some of the sensitivities, you can see there for a TEE, sensitivity ranges between 96 and 100%, and specificity around 86 to 100%. And that's essentially what it would look like if you used IVUS. You also know what it looks like when you're doing that with a catheter. You see that flap that's mobile within your ultrasound image. CT scans are obviously the most widely used, and that's because they're easy to do. They're available everywhere. You're not dependent on kind of technicians that are only there during daytime hours. It's quick and relatively inexpensive. As far as MRI, it's probably the best imaging modality, at least it has been in our hands, and there's definitely some data supporting that. if you look at this study done back some years ago now, but really probably the most sensitive of the 4 imaging modalities used for dissections. What is the rationale of treatment? Well, once a presence of dissection is established, you need to have some information from the imaging modalities you're using. So one is you need to know the extension of the dissection. You need to know which branch vessels are involved and how they're involved, proximal and distal entry sites, septal mobility and dynamic branch vessel obstruction. I'll show you what that looks like. True and false lumen filling patterns, false lumen thrombosis. You may know or not know that partial false lumen thrombosis is really linked to poor outcomes in these patients. Of course, rupture, but likely you'll know that from your hemodynamic status. And then aortic dimensions. Just quickly, there are different ways this can appear. It can appear as both a static and a dynamic vessel compromise, depending on whether there is some thrombus along that false lumen extending into some of those branches. If you look here, you can see on the top image, which is what you're going to get if you get a static image. You're going to think your vessels are open. If you look that down below in kind of a more dynamic projection, you can see that there's invagination of the septum into those branch vessels. And if you have a patient who has symptoms, you can understand why when you see those pictures, although you probably couldn't understand why if you saw the pictures up above, and you'd probably manage that conservatively. Again, here, just to show how dramatic it can be when you see some of these dissections in a more dynamic way. Of course, you realize that the aorta is an organ like any other organ, and there's something happening all the time. And this can change quickly as these dissections evolve, sometimes over hours to days. If you look at this, an old study based on some imaging criteria, and essentially there were 2 basic components, ischemic and benign configurations for dissections. Just something to keep an eye on when you're looking at your imaging. Here, just some MR that you guys probably aren't used to seeing, but really high resolution contrast MR, and you can see just as well as you can in a CT, although clearly a CT gives you better spatial resolution. And we'll show you some of those here in a second. Again, here you can see clearly your entry tear, and these are things that you should be looking for. We essentially looked at all our MRs and found 3 different forms of flow through these dissections. Type 1, which is really a very benign configuration where the flow is equal through both the true and false lumen. Type 2, which essentially is a dissection where you see antegrade flow and then slow flow through the false lumen, but the false lumen pressure stays high because it doesn't empty well through that re-entry tear. And then the opposite on the type 3, where it's really a retrograde flow into the false lumen. You can see how that hangs up at the end. Again, a high pressure circumstance in the false lumen. This is a ECG-gated CTA, and you can see a lot of the same dynamic components, and obviously very important, but you can do this in CT. It's a little more refined on the MR, as we showed you, which is really a cardiac MR protocols. If you are to look at aortic dissections as far as how to look at it by, there are always some blood parameters you can look at here. Really, D-dimer as far as biomarkers becomes the most important. If it's above 500 here, just a little flow chart here. If it's above 500, you should consider that there is a dissection. Not all ERs are used to doing this, but it's definitely something you can use. For type B dissections, really the mainstay is in the ICU, pain control and anti-impulse therapy. And then eventually, once you manage that conservatively, you want to switch over to PO medications, discharge on antihypertensives, and then CTs as outlined there. Indications for interventions we already spoke about. In the chronic phase, you look for aneurysmal degeneration of the outer false lumen, and then essentially the groups at risk, central continued patency of the false lumen flow is demonstrated as a risk factor. Partial false lumen thrombosis, as I said earlier, is a risk factor for poor outcomes. 40 to 50% of the patients will require some form of aneurysm resection. The therapeutic spectrum, As far as surgery, obviously type A, we said all those get surgery. You can have acute type Bs with retrograde dissection. Also, when you stent them, that can be one of the complications. And then you convert it into an open operation. And then for most patients, they will go through medical therapy for type Bs in uncomplicated types, uncomplicated situations. And then, of course, for most complicated or unstable acute type Bs, you'll have an interventional modality to treat those patients, and primarily that's TVARs or some combination of fenestration and so on. I'm going to go through some of this a little bit faster here. Overall in-hospital mortality is about 29.3%. If surgery performed less than 48 hours after initial symptoms, it's 39.2%, and then a little bit lower beyond that. Motivation to treat. This is just to really show that as patients get older, obviously they don't do as well no matter what modality you use. And then really pain in that slide, in that diagram on your left side, all high-risk patients are excluded. And the only thing you're looking at here is intractable pain, and those patients have significantly worse outcomes, so not something to be ignored for sure. I'm going to go through some of this stuff. Oh, we do? Oh, okay, great. Well, I'll go. So initial medical therapy, these are some of the medications that you can use, but ultimately what the goal is to maintain systolic blood pressure between 100 and 120 millimeters of mercury, maintain a heart rate below or equal to 60. The IRAD data basically says that 73% of patients managed conservatively. There's a 10% in-hospital mortality. 60 to 80% survival rate at 4 to 5 years, and then 40 to 45% survival rate at 10 years, which is not bad. Timing a stent graft, if it's the chronic phase, generally is less attractive and much more attractive in the acute or subacute phase. And that probably may change a little bit over time as we study this more, but essentially complete obliteration and resolution of the false lumen following endovascular stent graft treatment is more frequently achieved when you treat these patients in a more acute phase. I just want to go through 2 trials I think are important for you guys to know, and that's of course the INSTEAD trial, and then what you know from the INSTEAD trial is these are the most important things. There was no difference in all-cause deaths. 2-year survival also was equal between the groups, and essentially no difference, no advantage really to stent grafting these patients. But what you have to know is these patients were mixed. It wasn't powered, the study wasn't powered properly. And so really this is just should push us to understand the pathology a little bit better and which patients really need to be stented and which ones don't. The ABSORB trial is the other trial that's important. It's a Gore-sponsored trial. The primary study endpoints were incomplete or no false lumen thrombosis at 1 year, aortic dilatation at 1 year, and then descending thoracic or abdominal aortic rupture through the 1-year follow-up. And what you can see is that essentially true lumen max size increases after stent grafting over best medical therapy. And then here, the false lumen size decreases significantly in the TAG group versus best medical therapy. False lumen thrombosis at 1 year of 30 TAG devices and best medical therapy, 56.7% had complete false lumen thrombosis, 13.3% had none or partial, and then 30% had imaging unavailable, like is very, very commonly the case in our patients, and I think you'll see the same thing is most of your patients don't come back. They come from far away. Some of them just aren't motivated to come back, and so oftentimes we have incomplete records in all of these patients, which makes studying them very, very difficult. Of the best medical therapy alone, only 3.2% had complete thrombosis of the false lumen, which is obviously a huge difference. 64.5% had none or partial thrombosis, and then down there 30% equally. This is just to say that we are extending into the chest. This is a study that we're doing here in the medical center through 3 centers, Dr. Caselli, Dr. Safi, and ourselves, where we're essentially treating the ascending dissection with stent grafts, and hopefully we'll get some results out of this in the next few years. And so in conclusion, I think this is a relatively rare pathology with potentially grave consequences. Medical therapy still works and should be the treatment of choice in uncomplicated dissections. I think don't feel you need to treat everybody with stent graft, because that's also not without complications. You heard Dr. Lumsden's talk, and that's very much the case here as well. As far as endovascular repair, it's definitely probably the mainstay now for type B dissections, and who knows, it may be the mainstay for type A dissections down the road. Open surgical repair remains a valid option in chronic dissections and should definitely be considered as such. Thank you very much.